Welcome back to The Learning Curve, the podcast where we highlight the educators, innovators, and ideas that are reshaping medical training. I am your host, Dr. Irtaza Asar. Critical care and emergency medicine share a defining reality. That's chaos. When everything is happening at once, the alarms are sounding, the tasks are piling up, teams are looking to you for direction, the ability to think clearly becomes the most important skill in the room. Today, we're exploring how clinicians manage cognitive load in high-stakes environments, from ventilator crises to shock resuscitations, and how educators can intentionally teach clarity, calmness, and situational awareness when the pressure is on. Today, I'm joined by an expert. I'm joined by Dr. Nicholas Ghionni, and he is an incredible educator as well as an incredible intensivist, and he's going to help us break down how elite teams think under pressure and how we can train that mindset with purpose. Nick, thank you so much for joining me today, man. I really appreciate your time.
Appreciate you having me on, my friend. Thank you so much.
It's going to be a really fun topic, man. I was personally resonating with this topic a couple weeks ago. One of my residents got called into a rapid response, and I was like, "Hey, I'll give you like 5 minutes. You go first, and then I'll come afterwards, and we'll just kind of talk about everything when I get there." So he goes there first, and I come in, and I can already tell it's kind of like a deer in headlight intern moment where nurses are screaming. They're like, "Oh, he's got anaplasmosis. He's got XYZ, XYZ." The guy's like apneic.
Wow.
And then I pull the guy aside afterwards when we debriefed, and he's like, "Dude, I didn't even know what to do first because people were just bombarding me with a lot of information, and I just didn't really know how to process it because I walked in, they were saying, hey, he's got XYZ, XYZ, and I'm just not sure how to compartmentalize that information so I can make the best decision for my patient." Because I think a lot of the times we talk to folks about clinical performance, but we don't really give them good feedback on cognitive performance and how to kind of think under stress and how to manage that cognitive load. So I'm really happy to have your expertise on this topic, and I think it's going to be such a fun topic to explore. It's going to help a lot of educators as well as learners out there. So I think it's going to be good, man.
Absolutely. That's kind of random. Anaplasmosis, though, that's kind of one out of left field. So it was a rapid response, though?
Yeah,
Or,
it was a
like,
rapid response. Yep. And
are you EM, or do you do the rapids on the floor? Is that how it works? Or
so we do some rapids on the floors, and we do a lot of rapids kind of on the ground level. So I told my resident, I was like, "Hey, listen, why don't you go first, and then I'll catch up and I'll meet up with you because I want to see how you do and give you a little bit of autonomy to kind of make those decisions." So he was telling me he walks right in the room, and then the first thing people start telling me, "Patient's got anaplasmosis."
That's so random. Oh my God.
It was like totally random, and he just got caught off guard by it, and it was kind of a deer in headlights moment.
See, it's interesting you bring that up because I think the rapid response as a thing in the hospital, that's where I think the eternal battle between IM and EM, right? Like, is it COPD? Is it CHF? Do they need to be admitted? I think they're OBS. Did you get a CAT scan? What's the D-dimer? But the rapid response, I feel like, is the scenario where people who are internal medicine trained can get a taste of what it's like to be an EM physician, right? Because to me, I tell the residents and like everyone in general, rapids make you the EM physician of the hospital in some way. Because now, even if the patient's like got a diagnosis, they have anaplasmosis, whatever it is, but generally they call rapids because it trips some little sign thing or some. I guess in some hospitals, phylactic's like above 4. Like in my residency, if phylactic was above 4, for no matter the reason, it would trigger a sepsis response because they would want to get sepsis under control. So, you'd have to go there and figure out like what's the lactate from. Oh, it's, sometimes it was sepsis, and then we would sort of like resuscitate them and that kind of thing. Other times it was bleeding or whatever it was. But it goes to show certainly IM residents and really IM physicians to some degree, like when you get to a room and, things are spiraling out of control, like he's breathing 40, the blood pressure's high, like what, sort of like what you do next. It's very easy to be the deer caught in headlights. There's so many tasks to do, like what do you do first? And before I was a physician, even before med school, I very briefly worked as a waiter, like a very bad one at that. But when we would have sort of the rush, like on a Friday night or whatever, it's kind of the same thing. Be sort of deer in headlights. What do I do first? This table wants water. I got to put this order in. This table wants to check. So one of my managers, older guy, had a lot of wisdom, but he would sort of come by and always be, just do the first thing first. So just pick one and then do that first. And then once you do the first thing first, everything sort of falls in line. So for me, honestly, not to sort of bunny hop, but when I was a resident in my hospital, the call resident would be the rapid response sort of resident. And I was the same way. I was like, oh my God, I don't know. Do I get an ABG? Do I ask for labs? Like, do I do this? Do I do that? The one thing I always didn't do was ask for a blood sugar. So I wound up, I made a badge buddy for rapids because I knew I'd be under tremendous stress and I wouldn't be able to think clearly. So I would just look at my badge buddy, and no matter what it was, I would just say, did anyone get a blood glucose? And then the nurse would be like, yeah, it's 400 or something. And I'd be like, okay. But from there, it's sort of like reframe my thinking where, I had sort of a scripted way I would approach it, at least in the first couple steps, and then, let it sort of take me where it goes. But I think because we don't have a way to approach it, we just sort of like get bombarded by all these questions. And ultimately it comes down to like, does the patient need to move? Do we need to intubate them? Do they need pressors? That kind of thing. But how do you sort of manage that initial 5 minutes of, the plane is like spinning out of control? Like, how do we sort of get control initially and then go from there?
And I think about it like this too, man. And I'm curious to see from your experiences.
Yeah.
Did you ever get formalized education on this? Because for me, I never did. And it was just kind of this expectation that once you go
For
from
rapids, you mean?
for rapids or just even kind of a room control, understanding kind of cognitive load.
No,
Because it was
absolutely
kind of
not.
like this almost expectation that, hey, I went from a PGY to a PGY2. And now it's like this expectation that, hey, you should know how to manage this. When in reality, the only thing that's changed is it probably went from like June to July and now I'm a PGY2 and now I'm walking into a room and you're expecting me to be able to manage all these things. So that's why I think this topic it's almost like a blind spot in medical education of sorts, where I really think we can help a lot of different folks that are out there. So to set the stage for this conversation, can you talk to me about what cognitive load is? And before we start diving into some strategies that folks can employ, let's talk about why it matters for clinicians that are working in chaos almost every day.
To me, and I'm sure there's like a sort of textbook definition, but the way that I think about it is that you only have so much sort of like emotional and mental capital to spend. So you can spend it on talking to the family about an end of life situation. You can spend it on very much going through the academic discussion of shortness of breath. You can spend it on thinking about this like massive list of differential diagnoses that it could be. But, some of those, maybe you need to do a little bit of each one, right? But you only have so much mental space to make decisions, and you can only do it so fast. But I think one of the things that comes up a lot is like this, system one, system two thinking. So like, system one being sort of deliberate, system two being more sort of thoughtful. And, we sort of dichotomize it like people fall in one category or another. So very classically, EM is sort of a specific system, and then sort of IM is another system where we don't sort of we don't act fast. We sort of think about things more deeply. Whereas EM, while you think, you're acting much quicker to act maybe. So, certain tasks, and like a rapid response is a good example, where the cognitive load is high, but along with the cognitive load, I think in that scenario comes like the emotional load. So there's a great book that I read before where, and I can't remember the name of it, I can get it to you for the listeners, but essentially it comes down to communicating in stressful situations where as the stress ramps up, your communication breaks down and you get more emotional. So if you ask me a question in this very stressful state, I might just sort of snap at you because I sort of revert to that kind of fight or flight response. So the adrenaline's pumping, the patient's crashing, decisions need to be made. And it kind of comes down to, so like for the learners at least that are listening, I really think of like the Little Giant movie, The Little Giants. I mean, I might be dating myself, but where they talk about the pitch to Johnny and he's like, you can't pitch to Johnny, I'm Johnny. So, I think what we don't do a great enough job is having the trainees sort of be Johnny, right? Like letting them, and it comes down to the attending as well, I think to some degree, because how much freedom does the attending give the trainee to really stretch those muscles and go through that mental exercise of a high risk situation? Obviously, you want to balance being safe, but also giving autonomy. So it gets difficult, I think, to have that discussion.
Absolutely, man. That's honestly a good framework. And something that I've also talked to my learners about is that when you walk into that room, really, when we're talking about this idea of cognitive load, we're asking ourselves this question is that, hey, I have a certain capacity to be able to make decisions in this moment, but what happens when I'm overloaded with information and that's exceeding my brain's actual capacity to process that information, right? The more complicated the problem, the more likely this might happen, the more extraneous load that's there, whether it's distractions, people yelling, consultants yelling things, nurses saying certain things, anaplasmosis, that's all extraneous load. I have to shift my focus onto the actual intrinsic load, which is the medical problem that's in front of me, right? This patient is apneic. I have to figure out what has to be done for this. And now my mind is transitioning to that germane load, which is basically I'm trying to figure out what I need to do to be able to offload certain things and focus primarily on that intrinsic load. So do I need to tell people, hey, I need quiet right now? Or do I
Right.
need to tell the nurse, hey, why exactly was the rapid response called? What are the vital signs? What key pieces of information do I need to actually refine my decision-making process so that I can do what's necessary for this patient? So I think that was actually a great overview. And I love that analogy. And by the way, you didn't date yourself. I got the
Oh,
reference. We're good.
For
Okay.
the new learners, I don't know, it might be where the classics are starting to escape them, which is really terrifying, especially the old Adam Sandler movies or something. And that's I think the quiet thing, that's a point to really sort of underscore, because we don't want to seem that I don't want to say mean, but
Yeah.
aggressive or something.
Yep.
But and there's sort of a way to do it, right? Like, if you tell everyone to shut up, that's probably one way to do it, probably not a great way to do it.
Yep.
But maybe just say, hey, certainly crowd control, which is, if it's a resuscitation or CPR is in progress and there's a lot of people, and I think with good intention, like whether it's people who want to help, people who want to see if other people need help or do compressions, or maybe it's students. Like, there's a lot of students that haven't been a part of a resus, so they want to like just see what it's about. But if you have too many people in in like a tiny place and everyone's talking and sort of onlooking, you want to get control and say, hey, if you don't need to be here, please step out, because
Yep.
there's too many people and we want to make sure we have good communication. So I think that's like something that we probably don't do enough. I certainly don't do it enough. And I think that gets back to the load situation where you're sort of so focused on what's happening, you're not able to sort of spend some of that cognitive capital on like, okay, there's a lot of people in here. I can't hear myself think. The vent's going off. The nurses are screaming. Let's get some of these people out of here to like sort of calm it down, take the temperature down a bit. Because I think sometimes, I mean, I don't know about you, but I can feel like the collective angst sort
Yep.
of go up and up when the more people are involved and the more of like the chit chats going on and no one knows what's happening. Like, what are we doing? Do we have Ross? That kind of thing. So
No, I think that's actually a great point, man. And I felt like in the last couple of years that maybe it's me or I don't know. Like, I feel like the rooms themselves have gotten a lot smaller, or there's a
yeah,
lot more people in there. So now everybody's yelling, everybody's
that's so
screaming, and
funny.
we're trying to figure out, hey, what to do. Now it's time for crowd control and getting folks out of there so that at least the people that need to be in there can be in there and try to basically make the next best decision. So
and get to the patient too. Like, sometimes there's so many people, and then you start adding devices, right? Like, you get the glide, you get the ultrasound, now we need an X-ray. So then there's a bunch of people, a
Yep.
bunch of devices.
The room's getting smaller and smaller.
The room's
Yep.
getting smaller and smaller. Exactly. Yeah.
Yep.
As you
Yep.
add more and more stuff with more and more people. So
Definitely.
good,
And
good point.
I honestly, I think that's a fantastic overview. So now that we understand, how the brain becomes overloaded, Nick, the next step is to talk about how we can offload it. And we just talked about some things that we can do. Another thing that might help listeners are mental models and checklists. Can you talk to me a
Yeah.
little bit more about that?
I think they're tremendously helpful. I think they're helpful because and this is my personal experience, I know that as I get more and more stressed, I feel like I start to sort of like shut down a bit. My thinking becomes clouded. My vision gets like a little bit blurry. I don't know if that's from like my pupils dilating because of the sympathetic load that I'm sort of under. To myself, I'm like, okay, when I was a resident, I would think like, how do I sort of rescue myself from this? So what I did honestly was, like I said before, I made a checklist. So for example, for airway stuff, right? There's a Lemons mnemonic,
Yeah.
right? For like sort of pre-intubation stuff, the oxygenation, if you have the pulse ox on, the blood pressure cuff, all that stuff, suction, et cetera, et cetera. I wrote that down and I put it on my badge when I was a fellow. And, as I'm at the head of the bed, like we're getting ready to intubate, I would just look at it and just go through it. I have sort of a love-hate relationship with mnemonics and checklists because I feel like sometimes you can have a great mnemonic, but I still feel like it doesn't get to the root problem, which is that you're under that tremendous load. You can't remember to do anything. It's like, okay, let me remember this very complicated mnemonic about pre-intubation stuff, right? But you always have your badge on you and you can always look at it. You could be, okay, let me just look at my badge and see what's there. So for me, I mean, to this day, and I meant to bring it in, my badge is in my car, but I still have stuff on it. At the current moment, I have the steps for nasal tracheal intubation, like all the different lidocaine doses, like for like numbing the nose and atomizing, all that stuff. Because I don't know about you, but I've been a part of a few nasal intubations for, crashing angioedema stuff. And I'll tell you, man, when you're like, okay, we need nebulized lidocaine, and then everyone's like, all right, how much? What percent? And then everyone's like, I don't know, I think it's 3%. Is it 4%? Or is it 4 mLs of 3%? Or is it 3 mLs of 4%? So those numbers, they get very confusing in the moment. And even, and shout out pharmacy, everyone, but like, I think it's just a tremendous amount of stress. So stuff that you'd be able to answer very simply, not under stress, becomes very difficult to answer when you are stressed.
Yeah.
So whatever your role is, now, if you're an intern or whoever, I think you'll have to tailor maybe, one thing I would say is figure out what checklist you like or use or is useful to you, or even in the moment. Maybe if you're in the ICU, then obviously be more sort of like ICU stuff. If you're on the floor, rapid response, then it'd be more sort of geared towards that. But yeah, I mean, get checklists to help you offload your brain. So
Yep.
you don't need to think about like, okay, what dose of lidocaine do I need? All you need to think is, okay, let me just look at the badge. Let me look at the badge, and then we'll go from there. And then sometimes I use that as sort of a mind map where once I start seeing these keywords, my mind will sort of go in other places and I'll say, oh, it's got to be X amount of this amount of lidocaine, but we can't give more than 2 mg per kg because we'll give them lidocaine toxicity, right? So that's like 2 or 3 steps down the line that I got to tell you, I would never remember just sort of like off the cuff in a stressful situation. But because I was able to get to my badge and then think about like the downstream effects of like what we're about to do, I can sort of frame, my next couple steps based on what I'm looking on my badge. So I think checklists are great, and it depends on what you're doing, certainly. But the caveat with checklists is if you have too many of them, can you really remember them? But you can
Yep.
always write them down, right? You can always write them down, and you can always put them in your phone, which is what I did as well with other ones. But the ones that I need sort of on the spot, I put right on my badge.
Yeah.
So
And honestly, I think that's a fantastic point, and that's something that I try to stress to a lot of my residents is that, if you have 80 million checklists, you're going to
yeah,
run into problems, right? You
right,
almost have to simulate yourself as like an airline pilot where, hey, if I'm going to use this checklist, this is the same one that I'm going to use over and over and
right.
over again. And I also have to make sure that I don't try to deviate from that when the stakes are high, the pressure's on, because for me, this should almost be second nature, where if I'm in that situation and I have to use a checklist, I already know it. This is what I'm going to do so that I don't miss the small things, right? You're getting ready for an airway and then you forget your suction, right? And then as soon as you
Yeah,
push meds, all of a sudden there's stuff everywhere. You're like, oh my God, where's my suction? Oh, I didn't go through my checklist that one time and now look at me, I got burned, right?
ex-
And that's something that I always tell a lot of the residents is that, hey, your checklist is not meant to be like a hard crutch for you. It's meant to be a scaffolding of sorts where
yeah,
you're using this to basically simplify certain decision-making processes so that your mental bandwidth can be reserved for the things that you need to be worried about, like critical decisions or anything else along those lines. So you have your checklist ready to go. You've figured out, I've got all your airway stuff set up. Your mind can then just focus on the airway. You've already
right.
got your suction set up. You've got your RT in the room. You've already done all those things. I also like the dopes mnemonic for a lot of the ventilator troubleshooting in that phase where somebody's acutely crashing on the vent, nurses are freaking out, RT is freaking out, you're walking in the room, people are screaming. You have to be able to internalize that in your mind that, okay, this is the steps that I'm going to take. If you have that mental framework ready to go, it'll just make your life a lot easier. And at least that's
Yeah,
from my experience has been something that's really helpful because it also, I would say almost it's a little bit of like a cognitive pause point for you in a way where you can create these intentional moments to basically recalibrate. Okay, so the vent alarm is going off. Something happened acutely to this patient. I'm going to go through my mnemonic and I'm going to try to figure out what exactly is going on. Did the ET tube get displaced? Did the ET tube get obstructed? Is there a pneumothorax, right? So you're deliberately building these little small checkpoints to make sure that you can recalibrate and actually force yourself to think about what needs to be thought about.
yeah. A former co-fellow of mine, he would always joke that he would just pocus people because you're ultrasounding someone, people tend not to bother you with little ticky-tack stuff. So if the patient's like crashing and you're at a point where you can sort of breathe and the neuroepi's at 40 and you're not really sure what's happening, are they bleeding, is it sepsis, whatever, and everyone's like, okay, what do we do now? Do we need to do this? Should we get lab? Should we get ABG? Should we, all these questions, and you still don't know what's happening, so you can't really make a decision just yet because you're not sure what's happening. So he said he would just start focusing people. And while it's giving him information, people are leaving him alone. And then he has time to think about, okay, what am I going to do next? I got to be honest, I do that to this day when things are spiraling and we get to a point where we can sort of pause and what's our next move, like our next major move. I usually just focus the patient because no one comes in and starts to bother you more because they're like, oh, like Nick's doing an ultrasound, like just give him a second so he can figure out like what's going on. You know what I mean?
Yep.
So I tell the residents like that's creating time and space. Sometimes unfortunately, there is nothing to do except think about what's happening. Like at some point,
Yep.
there needs to be like data synthesis. So you've gotten all this data, and then we need to synthesize it and then figure out what we're going to do next. I mean, that takes a half a second, right? It takes like some time. Sure, if it's a like pulse ox is 40, there's not much you need to think about. But when the vent's alarming, you've gone through your mnemonic, it's not a pneumothorax, it's not bronchoconstriction, it's not like the patient's not biting, et cetera, but like the peaks are still high and like the plateau pressure is kind of high. It's like, I'm not really sure what's happening. You get an x-ray, you can't tell, is it edema? I'm not sure, and maybe, so you're going through it and you're like, okay, like what else can give me high peak, high plat, the patient's critically ill, and then you get to and everyone's like yapping at you, like, should we get an ABG? Should we do this? Do they have ARDS? Should we try PRV? Should we call for ECMO? And then you get to the conclusion, you're like, oh, wait a second. What if it's abdominal compartment syndrome? He had pancreatitis and they gave him a bunch of fluid for the past couple of days. And that's a third or fourth order operation, right? Yeah. So you've gone through your mnemonics, you've sort of rescued the patient, you've stabilized them, but at some point you need to sit there and think about like, okay, what could this be? Go through your differential, but that takes time, especially when it's something that, is not sort of readily apparent, I guess. And for me, that happened recently, a patient with like high peak, high plat, that had pancreatitis. I know they had worsening shock, AKI, and I'm like, I don't know, like and everyone's, so anchored on maybe they have sepsis, whatever. And I'm like, well, how much fluid did they get? And then we sort of look and, their cumulative for this day is like plus 15 liters. And I'm like, I don't know, I think it might be ACS. We better rule this out. And lo and behold, it was ACS, meaning abdominal compartment syndrome, not like the other ACS. Yeah. So, but that's not a rapid fire question, right? If I gave you that question stem and gave you 2 seconds to answer, I don't know if you would come up with abdominal compartment syndrome. There's a lot of things that are more likely, but as you work through the problem, you might come to that conclusion, but you need time, right? So you need to create time and space.
No, that's a really fascinating example. And I think it really ties into what cognitive overload can do to us as clinicians, especially under high stress, right? So when I think of this, I think it speaks to the idea of situational awareness and just kind of thinking about that example that you just gave us, right? So when I think of situational awareness, I think of it being broken down into 3 facets, right? Perception, you're noticing what's happening. Okay, the peak pressures are up, the plateau pressures are up. I notice something is off, right? The next step is comprehension, understanding what's actually happening. And then the last step is projection, which is where you're going to anticipate what will happen next. And the idea there is that your cognitive overload in that moment, if you don't have it under control, it's actually going to erode all 3 levels. So your perception is going to be affected, your comprehension is going to be affected, your projection is going to be affected. That's really where a lot of these checklists, mental models, taking cognitive pauses can really help so that you can make sure that your situational awareness is as sharp as it needs to be so that you can come to the right diagnosis within a reasonable time. So I think that's actually a really awesome example. Are there other strategies that you have for basically trying to teach this situational awareness? Because I think this is something that we don't really talk to our learners about enough. But just from your experience, have you found anything that's really helped you?
I think creating the checklist and putting it on your person is something that's underused. And I try to impart that to whoever I'm training, like the interns and residents. Number 1. Number 2 is if we're going through a resus or something's happening, I really try to let them guide it as like practice for them to understand the decision making, the thought process. And, sometimes you get to the end of the algorithm and there is no answer. I still don't have an answer, right? So the patient's crashing and maybe the resident goes through the whole workup and we sent these off, we sent the labs off, we did a POCUS, we are going to get a CAT scan and, X, Y, and Z. And sometimes I think they want a answer. And sometimes there's not an answer, right? Like there's no answer. And you need to be comfortable with that. And you need to be able to sort of predict what's going to happen to some degree. Let me take a step back. I can see things progressing in some way, like in my mind's eye, meaning if the patient's hypotensive, right? And the nurse maybe can't get a blood pressure every now and then. And they're like, I don't know. So you check the other arm. And then we check the other arm and we really can't get a blood pressure on that arm. And then we start going for the legs. I'm like, I don't know if we can get a blood pressure on the leg. It says it's like 150 over 40. I don't know if I believe that. So then ultimately someone says, let's put an A line in. So then the residents like mess around with the A line. And then at some point I walk in, I'm like, what are you guys doing? I'm like, well, the nurse can't get a blood pressure and, we're going to put A line in. I'm like, well, how's the patient? And they're like, oh, I don't know. He's kind of sleepy. I'm like, I go and look and he's like obtunded. I'm like, all right. So, what do you think's happening?
Yeah.
Right. So they're getting worse and worse and worse. We're so hyper focused on we need a number. But in reality, do you really need a number? Can you see what's happening here? Those are teachable moments where I think once you point out like what's happening, the patient's getting much worse. And then, you get the A line in and it's like the pressure's 60 over 40.
You already knew
could
that,
we have
right?
assumed?
Yeah.
Yeah, could we have assumed that before?
Yeah.
And is it
100%.
going to change our management, which is norepinephrine increasing? So what I mean is those moments are hard to teach. I feel like the best way to do it is the shadow boxing technique where you come up with a clinical question, you set the stage, and then you see where they take it. So I think 2 years ago or last year, we did sort of a rapid response simulation. I feel like rapids are hard to simulate, but you can certainly come up with scenarios where, rapid was called for bradycardia, let's say, right? And you get to the room and the patient's bradycardic to 50, what next? And then ultimately, someone says like get labs and blah blah, and I sort of need to like remind them like, did you ask for a blood pressure? What's the blood pressure? And they're like, oh yeah, what's the blood pressure? And I'm like 150 over 40, because that completely changes everything, right? So
Yep.
like if let's maybe not 50, let's make it more sort of like esoteric. Let's say like 48 or something, right? So like below 50, sort of low enough to maybe trigger a rapid response, and then you get to the room. It's like, what's the blood pressure? It's 150 over 40. It's like, okay, so maybe it's just like sinus Brady. It's not sort of a worrisome issue. But if you get to the room and it's 80 over 40 and the patient's obtunded, like that's much different. But the next question is, do you need labs for that situation? I mean, do I need an ABG? I think I know what I'm going to do next, right? I usually tell them if you approach it from like an ABC mindset, meaning like air, breathing, circulation, you can get the patient out of hot water. And then once you sort of rescue them from that situation, you can start to figure out why. Is it too much beta blocker? Are they hypercapnic? Did they take something? Do they have some overdose? Like that kind of thing. You know what I mean?
That's actually a great point. And that's something that I think I've personally struggled with as an educator as well, is how do you teach people to be proactive? And going back to that point about the 3 levels of situational awareness, right? Perception and comprehension are not as difficult to teach because people get a lot of experience in those situations. They find themselves in those moments. So they just pick up on, hey, this is what I have to notice. This is what I have to understand in this situation, right? But it's that anticipation or that projection of what will happen next. And the analogy that I often tell my residents is that by the time you try to graduate residency, my hope is that you don't play checkers, you play chess, right? You're thinking 2, 3, 4 moves ahead. You're
Right.
anticipating, okay, this patient's hypotensive. Why are they hypotensive, right? If I reviewed their chart, I saw that they were recently diagnosed with a pulmonary embolism. Are they taking their anticoagulation? Is that why? Is this obstructive shock? Now I'm already trying to anticipate what will happen next. Do I need to get them to CT? What's my bedside POCUS going to tell me right now? Do I
Right.
need to get my interventionalist on board early on so that in the event that this patient deteriorates, I'm ready for thrombolytics, I'm ready for whatever else needs to be done, right? I'm
Right.
thinking 2, 3, 4 steps ahead so that I can set myself up for success, as opposed to thinking, oh yeah, you know what? I haven't gotten a pressure in the last 15 minutes. Now's the time to maybe try to go for that A line. And then in the back of your mind, you're thinking, I already know my A line's going to tell me the pressure is low. What am I doing about that? What is happening?
Exactly.
Why is that actually happening? And I think that's actually one of the most challenging things, at least from a medical education standpoint with this topic, that I think I've struggled with. And again, a lot of it kind of really boils down to trying to put your learners in those situations where they have to basically try to think. And I think your example was really great. Something that I've tried is try to simulate situations with distractions so that they can try to basically find themselves in those moments and be forced to try to anticipate what's next, right? So that patient that's bradycardic with a heart rate of 40, right in your face, I'm taking a stop and I'm telling you, hey, their mental status is affected. I want you to ask me the blood pressure. I'm not going to tell you, but I
Right.
want you to ask me that to be able to anticipate that and then make decisions based off that and then try to get the right people on board to try to get this patient situated.
Can I tell you a
Yeah.
separate story? This is like this speaks to anchoring and that kind of thing. So one of the about probably like 2 years ago, there was a patient that came to the hospital a lot. She had a ton of past medical. She was overall like a sad case. She had some surgery and sort of went awry, and she's just been chronically ill. She always come in with AKI and always thought she had UTI and that kind of thing. Chronically low blood pressure, also chronically hypothermic, which I feel like hypothermia is the worst thing because no one ever really knows what to do with. The core temp is 35 and you're like, I don't know. I mean, are they septic? Are they not? I'm not sure. She'd been up, down, left, and right worked up for these things. And we chalked it up to that she's chronically ill and malnourished and all that kind of stuff. So she comes in for her normal sort of whatever. So she's on the floor, sort of floundering. We get a consult, and the residents thought she had adrenal insufficiency. Endocrine, that past week, had worked her up for it, like did Costantropin test. It was negative. They're like, she has no AI, stop giving her steroids. It's not AI. It's like, okay. So she's hypotensive yet again. She's hypothermic yet again, but she's like more drowsy. So, it triggers a rapid response. So the residents go up and evaluate her. They come down and tell me. And they're like, yeah, she's hypotensive. I'm like, what's the blood pressure? They're like, it's 70 over 40. I'm like, okay. I mean, that's like kind of low. They're like, yeah, but she's always low. I'm like, yeah, but it's a little bit more low than, I mean, I can sort of bless. And then I'm like, well, how's her exam? I'm like, oh, she's sleepy, but she's always sleepy. And I'm like, yeah, but I don't, And they're like, well, we think it's AI. I'm like, so I'm looking at the chart. I'm like, but Endo said it wasn't AI. And they're like, yeah, but we think it's AI because, she whatever the reason was, right? And
Yep.
I'm like, listen, this is like a definition of anchoring, right? She's hypotensive. She has a little bit of a white count. She's hypothermic. So can it be AI? I guess. But like, let's remember that endocrine ruled her out for AI like a week ago. So
Hmm.
does she now have AI all of a sudden? But even if that's the case, even if it winds up being that, is it the wrong thing to do to like bring her down, put her on pressors, give her antibiotics, and see if she has like an infectious cause or something else? And they're like, and sort of, so you can sort of see the wheels turning and like, oh, I don't know. So long story short, she comes down. She is in fact very hypotensive. So hypotensive that I usually go against what I do normally. I'm like an art line miser when it really comes to sort
Yep.
of the general septic shock. Because I think if you just go up enough on the pressures, like you're going to get a blood pressure. But I couldn't really get a pressure, right? So I'm like really nervous. I'm like, oh man, this is, her pressure either must be super low or something. So I quickly put in a radial art line, and sure enough, it was 60 over 30. And I'm like, I don't know. I feel this is like a lot lower. So
Hmm.
very quickly, we worked our way up to 90 of norepinephrine, vasopressin. She's like peri-arrest. We gave her antibiotics. We gave her steroids, the whole kit and caboodle. We wind up scanning her and she has a perforated gallbladder, and then she was bacteremic.
Hmm.
So, I'm like, you guys are anchoring because she's here all the time.
Yep.
She's always hypotensive. She's
Hmm.
always hypothermic. She always looks like she's septic. But that doesn't take away from the fact that if it happens while she's here, you still need to do the workup. Now,
Yep.
don't get me wrong. You bring her down, you like her blood pressure maybe isn't as bad as you thought. You gave her a dose of vanxocin. You rule her out for sepsis in the next 24 hours. Stop the antibiotics. No big deal. But to miss that opportunity to really be able to intervene, that could be very costly for her. You know what I mean? So
Yeah.
I feel like it's an important thing that ties into all this, and I think you're going to get into it, is the system one, system two thinking and
Hmm.
heuristics.
Yep.
And what it comes down to is our mental models and what is expertise. It's a lot of things, but one thing that it is for sure is when you've seen enough things, it sort of starts to fit a pattern. And then when you're under this cognitive load, it's like, what pattern does it fit?
Yep.
And when you're an expert, you can sort of see that. I had this case before many times. It's like fitting this pattern. That could be dangerous because if it's not that and you're making assumptions, that's where like the heuristics comes in, where you need to have some safeguards against, whatever the bias may be.
Yeah. No, I honestly, I think that's actually a really awesome story that really speaks a lot about decision making under uncertainty. And I think one of the key takeaways for me from that story is that you're forcing yourself to have these deliberate checks to actually slow down and shift from that type 1 to type 2 thinking, right? And you echoed this before, right? Is type 1 is that instinctual reflexive response that this is what I normally do, this is what
Right.
I'm normally going to do in this situation. But then type 2 is more so, hey, I'm going to grind it out, I'm going to slow myself down. Does the information that's in front of me actually fit the actual clinical scenario, right?
Right.
This patient's pressure is 60 over 30. That's not normal. I get that she's been hypotensive, but she's obtunded. Pressure 60 over 30. She's got a white count. There's a lot of information here that's going to prevent me from what I call premature closure. If I get information that's concordant to what I'm thinking, I'm automatically going to stop and just say, hey, listen, I'm done. We're done. This is the diagnosis. This is what it is. This is what I'm going to anchor on. But I'm forcing myself to stop and say, hey, does this actually make sense? 60 over 30 is very, very low. This is not
Yeah.
something that she's been at before, right? Her mental
Right.
status, she's obtunded. I have seen her 8, 9 times in the last 2 years. This is not her mental status, right? So now
Exactly.
I'm forcing myself to stop from doing what I call premature closure and anchoring onto a specific diagnosis. And I'm forcing myself to think. This is definitely a lot harder. It kind of goes back to your shadow boxing point. You have to box
Yeah.
yourself out of just stopping and thinking to yourself, okay, I'm done. No, I'm going to take my time. I'm going to create these deliberate checkpoints to make sure that my thought process is methodical and that I'm doing what's right for this patient. So that,
Um,
honestly, I think that was a great example.
Businesses do this too. It's called identifying black swans. So a black swan is like the business world calls like what is going to cause something to fail, and then trying to identify that before. So you assume that you're going to fail. So in that scenario, and I had just learned about it actually, so I used it with them. I'm like, what if she dies? What if she dies? What will you wish you would have done right now
Yep.
with that information?
Yep.
And they're like, oh, I wish I would have got a CAT scan. I wish I would have gave antibiotics. I wish I would have
Hmm.
given steroids, whatever. I'm like, then why don't we do it? Like, why don't we do that? Now, obviously, if they say like, we wish we would have like, I don't know, did Plex or given her chemotherapy. I mean, there's like sort of limits to this, but
Sure.
are there identifiable things right now that we might be missing that because of our heuristics, like we've seen this before, we've seen her before, she's been hypotensive before, she's been hypothermic before, she's fitting that pattern. How do we break that pattern thinking? And how we
Yep.
break it is by doing these cognitive pauses. But in this scenario, it's identifying the black swans. And
Yep.
there's like a whole thing about black swans, like what they represent and how you can combat them and how you identify them. But the key thing is assuming that whatever plan you have failed, and what do you wish you would have done right now with that information? So almost like a Bayesian approach, like you're looking back and seeing, whatever we thought was wrong, the patient died. Like, what do we wish we would have done differently right now?
Yeah. And I really like how you had this conversation with your residents afterwards, because I think that's really the best time to set them up for success for the future. Because I think quite often a lot of debriefs tend to miss that key point where
Yeah.
I think if you sit people down and say, hey, let's talk about some of the decision inflection points, right? Where did we go wrong and why did that happen? It's not meant to be a critique of, hey, you guys are dumb or anything like that, because again, that's not productive. It's more
Right.
so meant to be is, hey, where did our intuition and our analysis diverge and why did it diverge? Where were the biases that were at play? And I like to call this the cognitive autopsy, where I internally do this with myself for high stakes cases where whether the outcome is good or bad, I pull myself back after the case and I ask myself, hey, listen, where were those key decision points that had to be made for this case? Why did they get made? Were there certain biases that caused them to be made a certain way, right? I think if you have a conversation about specifically those decision tree branch points, I think that can help you really tackle some of those black swans that you were alluding to and set your learners up for success. Because again, I think quite often we talk to residents about clinical performance, but we don't really debrief on them on cognitive performance.
Yeah.
And I think that's something that as educators, I think we can definitely do it a lot better. Because again, our residents look to us to be these models for calm, structured communication.
Right.
So in those debrief moments, I think that's a great time to actually, aside from just talking about the clinical performance, but to also talk about the cognitive performance and try to make sure we can set them up for success. So I think that was actually a really great overview of that. All right, man. As we're getting low on time, do you have 3 key big takeaways that you would share with a first-time listener that's listening to this topic for the first time?
Yeah. I think the concept of creating time and space is important. Creating time to think and, creating the space to do it. It gets tight in these rooms, both literally and figuratively, as you start to have these machines that start to go off and they're beeping and everyone's getting more and more frantic. Sometimes you need to create this time and space. And, I don't know what that is for everyone, right? For me, it's doing a POCUS. I say, hey, can someone get the ultrasound? Let me just take a quick look. And even if I already know, I mean, I usually POCUS anyway, sort of is my approach to a lot of things. But even if maybe I POCUS before or something, like I'll just do it again because number one, and it serves 2 things actually. Number one is that it brings us back to the bedside, which obviously I think certainly in the past 10 years, we've drifted away from the bedside, more in the EMR, more in these different scenarios that we may need to be in, meaning like multidisciplinary rounds or whatever it is. We spend less and less time at the bedside, especially if you can ask the patient questions. Because for me, when I'm focusing, if they're awake and alert and they can sort of answer questions, you kind of like be surprised where the conversation goes. Things that they didn't mention before that now become pretty important. Whether it's like, oh, you know what? I did have a PE like 5 years ago and, they put me on like Coumadin and I was off and, they said not to worry about it. You're like, oh, is this like a hypercoagulable state? Is it a thrombus? Whatever. So I don't know what creating time and space is for you. Is it just, I don't know, is it saying like, all right, I have to go use the potty and you sort of go to the bathroom, whether you need to or not, you just sort of sit there and you like regroup, recalibrate, think about your next step and make that deliberate. It's almost like kind of scripting your plays. If you are a football watcher, I'm an Eagles fan because I'm from Philly originally. And like Andy Reid, I believe would script the first 20 plays or
Yeah, the
something.
first tries, yep.
So yeah, so maybe you need to script the first 20 plays. When you get
Yep.
to a rapid response, my scripted play was, what's the blood glucose? So it was irrelevant if I needed it or not. Like that would just be my starting point. Like, what's the blood glucose? And then, a nurse would be like, oh, we checked it. It's 115. I'm like, okay. And then, I would go from there. But, it's like scripting your plays, creating time and space. Maybe the second one could be scripting plays. And then the last thing would be, if you have time to think, definitely think about what you're missing. So the black swan identification. The other point of the black swan is that exercise is getting everyone on the team to feel comfortable voicing their opinion.
Yep.
Lowest person on totem pole, for example. even though I think like everyone's sort of equal, there's perception of like who's like, who's a
With higher
physician, who's the nurse, who's the
hierarchy and
RT. Yeah,
stuff. Yeah.
exactly, exactly.
Yep.
But getting everyone to sort of buy in when things are spiraling out of control and I'm not sure what's happening, I need ideas. And I tell
Yep.
the residents then, the interns and the nurses, the RTs, I'm like, what ideas do you have? And they're like, oh, I don't know. I think you're right. I think it's sepsis. I'm like, forget what I think. It's not about what I think at this point because I'm stuck in my box. Am I biased against my own thing? Do I just want to be right?
Mhm.
Like, what do you think? So that's where setting this black swan up is helpful because when you assume you're wrong, it gives people sort of the psychological safety to voice opinions that they might not have voiced before because they don't want to seem like they're going against the attending. They don't want
Yep.
to seem like they're going against the resident. They don't want to seem like they're going against the team. So you'd be surprised with the answers you get in a multidisciplinary fashion. Like, assume we're wrong. Like, what are you thinking? And sometimes people come up with like great ideas that I, would have never thought,
Mhm.
especially because I'm like sort of mediocre smart, honestly. I'm like not the brightest guy ever. There's a lot of residents that are a lot more intelligent that maybe are closer to the books. Like I've been doing critical care the last 4 years. My mind is basically a big COVID cloud. I forget about ITP. I forget about TTP. I forget about HUS. I forget about, these syndromes that can certainly be at play, but I'm so focused on certain things. So, making it safe for everyone to voice their opinion. It's not sort of this pie in the sky idea. It's actually real. And I think when you do that, you get ideas from other people. It's really helpful.
Yeah. No, honestly, I think that's a great point. And, that speaks volumes to trying to create that environment where your learners feel comfortable to be able to share their thoughts. Hey, listen, I might disagree with you, but this is kind of my thought process as to why I do that. And that's something that I stress to my learners too. I'm like, hey, listen, like, tell me what you think, right? Because at the end of 3-4 years of training, I don't want you to think like me. I want you to think like yourself. And the only
Exactly.
way that you can do that is if you actually articulate to me what you think is happening versus just going off with what I'm saying. Because granted, yes, as an attending to some extent, we're probably going to lean towards what I'm doing. But
Yeah.
if you have a great idea, I'm more than open to adopting that or trying out a new thing where potentially that might actually help our patients. And I didn't even consider that. Even if you're overloaded, you still have to make decisions, right? You have to be
Right. Yeah.
intentional with what you do. And the only way that you can succeed in the future when you find yourself in that anaplasmosis situation or the patient that's well known to your ICU that frequently comes there, who's now hypotensive, who's had an acute change in their clinical status, is if you force yourself to make decisions, under uncertainty and you actually live with the consequences of what you're doing. That's how you're really going to learn. My 3 key big takeaways. Number one, you want to try to simplify that environment to the best of your ability, because if you simplify that environment, you simplify the medicine, it makes decision making a lot easier, right? And then you talked about, using structured mental models and checklists. That can really help to offload a lot of this information that's on our plate so that we can really focus on the details that need to be focused in on, right? So I've got my airway checklist done. I can just focus on the airway because the airway is the most critical thing that needs to be done right now. And the last thing, again, is teaching clarity to be intentional, because chaos is always going to be there in critical care and emergency medicine. It's always going to be there. We're never going to get rid of it. But the confusion doesn't necessarily have to be, because again, this is a skill that you can constantly refine, reshape so that you're ready for that moment when it happens again. And I always tell residents, you're never going to rise to the occasion. Nobody ever does that. That's a myth. You're always going to fall back to the foundation of your training, and you're going to fall back to the level that you were trained at so that you can make the decisions that, you need to make. Now, as time's running low, man, is there any place on social media where folks can connect with you if they have any questions about cognitive overload, running rapids, or anything else, or even ventilators for that matter, where they can connect with you?
We're mostly on Instagram right now at Palm Toilet, and then YouTube, same handle. Twitter, same handle as well, though I'm less active there. So just like in the past couple of years. TikTok also, mainly on IG at Palm Toilet. Do a lot of like ventilator teaching on there. And
You got a new podcast too, right?
we have a new pod. Yep, we have a new pod, the Peak Inspiration podcast. There's plenty very good critical care pulmonary podcasts. But the one place I feel like we don't teach well enough in that space is the ventilator. So I'm, using it more as like a place for that teaching specifically. So that's sort of been the basis of it.
Nick's content is fantastic. I've been following him for quite some time. I've learned a lot about ventilators and vent alarms, and he really
Appreciate that.
distills concepts down in a way that's easily digestible. So for anybody that's looking towards getting more information on cognitive overload, or even just kind of simplifying the ventilator and demystifying some of the things that come with vent theory, Nicholas is your guy. Check out some of his content. He's fantastic. Palm Toilet on Instagram is definitely one of the best accounts out there, so I would definitely check that out.
Appreciate
So
that, sir. Thank you.
yeah, absolutely, man. So as we wrap up today, I hope this conversation reframes how you think about performance under pressure. It's not as something you're either born with or not, but as a skill that can be deliberately learned. Managing cognitive load, maintaining clarity, and leading calmly in chaos aren't just critical care skills. They're educational responsibilities. The way we model thinking, slow down decision-making, and create psychological safety shapes how our learners will perform when it matters most. A huge thank you to Dr. Nicholas Ghionni for sharing his insight, experience, and practical frameworks for thinking clearly in high-stakes moments. If you found this episode valuable, please consider sharing it with a colleague, a resident, or a student, and don't forget to subscribe as you don't want to miss future conversations on the ideas shaping medical education. Until next time, stay curious, stay intentional, and stay learning.